Good evening, everyone, and thank you for joining us tonight. My name is Dr. Bill Tulo, Medical Director here at Oculus, and welcome to tonight's clinical webcast called Fuchs Dystrophy and Cataracts, using the OCULUS Pentacam to guide treatment. You can notice a text box on the GoToWebinar screen where you can enter questions. Enter your questions at any time during the webinar, and at the end, we'll take time out to answer your questions. Tonight's speaker is Dr. Beeran Meghpara. Dr. Meghpara is a fellowship-trained ophthalmologist who specializes in cornea, cataract, and laser refractive surgery. He's a co-director of refractive surgery at Wills Eye Hospital and a full-time faculty member of the Cornea Service. He's an enthusiastic teacher and enjoys speaking at local, national, and international meetings on anterior segment surgical challenges, including the management of Fuchs dystrophy. I'm looking very forward to tonight's presentation, and welcome, Dr. Meghpara.
Thank you so much for that great introduction. Thank you for the invite to speak, and definitely thank you to all of you joining us this evening. As was mentioned, I'll be talking about Fuchs dystrophy and cataracts and how my approach is to dealing with these patients. You know, this is something that I'm really interested in. It's also something that's quite challenging. How to come up with a treatment approach when a patient has both Fuchs dystrophy and cataracts. And what I mean by that is, surgically, do we just want to do the cataract surgery? Do we want to do the cataract surgery plus some sort of corneal transplantation procedure? So for the next 45 minutes or so, I want to walk you through my approach and how I handle these patients. These are my financial disclosures. Of note, this talk tonight is being sponsored by Oculus. And as you just heard, feel free to ask questions. There is a text box in the application here. So as questions come up, definitely ask them and we'll address all of those at the end of the webinar this evening. So really what I want to know when I'm seeing a patient with both a cataract and Fuchs dystrophy is the Fuchs dystrophy visually significant? And what I mean by that are two things. I want to know, number one, if I perform cataract surgery by itself, what are the chances that the cornea is going to decompensate afterwards? And number two, how much of the vision is being limited by the Fuchs dystrophy and the cornea, in addition to the problem being caused by the cataract? The way I approach this, mentally at least, is first, I look very closely on exam. So the best tell sign that the cornea may decompensate after cataract surgery is if there are already signs of clinical edema on exam. So using my slit lamp, I think that's one of the most important tools. I'm looking for sometimes obvious signs of corneal edema or sometimes more subtle. So I'm looking for folds in Descemet's membrane, looking for stromal thickening. Sometimes I'm looking for epithelial changes like microcystic epithelial edema or epithelial stromal clouding that can be more subtle. And certain ways to pick up on that, instead of just using a diffuse illumination, is using either retroillumination, as you can see here, where we have goutte, but if you look in the middle, things just look a little bit more smudged, and those are areas of both stromal and epithelial edema. Another exam technique that can be used is sclerotic scatter. Now, this is a great way to pick up clinically apparent edema, but there are some limitations. It is a subjective evaluation, and there can be inter-observer variation. So my assessment may be different than your assessment, who may be different than the next person's assessment. But this is a great start. The second thing I look at is the cataract. And I'm really looking at two things. I'm looking at the density of the cataract, the grading of the cataract, and I'm also looking at the anterior chamber depth. So if I have a really dense cataract, or if I have an anterior chamber that's on the narrow side, these are both things that make me worry that even in the presence of milder Fuchs dystrophy, this cornea may not survive and may decompensate afterwards. Not necessarily pushing me to do a combined procedure, but at least provide the patient with adequate counseling in terms of what to expect as far as vision recovery and a potential second surgery afterwards. Now, these are both techniques to look on exam, to look for signs on exam for risk factors for corneal decompensation. But what about some more objective testing? What about diagnostic testing? What about looking for subclinical edema that may not be readily apparent on exam? So there's different things that us cornea specialists do. Probably the most mainstream is looking at central corneal thickness, looking at ultrasound pachymetry. And the number that's been thrown out there quite a bit as far as a cutoff goes is 640 microns. And this number was first published in the literature in 2005. And the way these studies are conducted is these studies look at patients that are scheduled to undergo cataract surgery by itself in patients with Fuchs dystrophy and a visually significant cataract. And a preoperative measurement of corneal thickness is taken. And then these patients are followed after the cataract surgery, and the amount or the number of patients that decompensate requiring intervention is then looked at. And then you can go back and then determine, what is a cutoff of preoperative corneal thickness where there's a high likelihood of decompensation after the cataract surgery. So in 2005, when this study first came out of Wilmer, this was a great study. But the limitation here is it doesn't take into account what the patient's baseline corneal thickness is. So for example, if we use a cutoff of 640, there are patients out there that may have a baseline corneal thickness of 600 or 610. And what we're implying is that if the corneal thickness has gotten bigger, then maybe there is some clinical or subclinical edema there that, again, is risking further decompensation after cataract surgery. But if the patient already started out with a thick cornea, then that number of 640 may not be as relevant. So having an absolute cutoff of corneal thickness doesn't really apply to all patients. The other thing to take into mind is, like I said, this was published in 2005. And these authors looked at data ranging from 1990 to 2002. And at this time point, the surgical option of choice for Fuchs dystrophy was penetrating keratoplasty, a full thickness corneal transplantation. As you all know, that is a fairly large surgery with a prolonged recovery time to maybe a year and a half, with suture removal that occurs over time, contact lens requirement oftentimes afterwards. So it is an ordeal, and these patients did see well afterwards, but it was an undertaking, and patients had to have a certain level of vision before surgeons thought that it was worthwhile to undergo this. Nowadays, our threshold to intervene when it comes to endothelial disease, specifically Fuchs dystrophy, is a lot lower. And we'll talk about some of the different techniques that we use, but especially with the advent of DMAC, with quicker recovery times, lower rates of rejection, we are intervening sooner and sooner. So again, that threshold would likely go down at this point in time. But that is where that number of 640 microns came from. The other thing that a lot of us look at are endothelial cell counts. And in the 2017 preferred practice patterns by the AAO, several things were mentioned to look at. And one of them was corneal thickness, one of them was clinically apparent edema, and the other one was a low endothelial cell count on specular microscopy. Now, the challenge with this, though, are patients that have moderate to severe Fuchs dystrophy, we can't get a great cell count. So for example, on the left here, we have a patient with a normal endothelial mosaic. And here we would get a very reliable cell count. This patient probably has a cell count of 2,500 to 3,000. In the middle, we see a patient with mild to moderate Fuchs dystrophy. And you can see these dark oval circular areas, and those are corneal guttae. And in between, we see some irregular endothelial cells. Now, we could probably get a cell count here, but if you're going to do that, it's really important not to use your device's automated counter. So these are the patients that you actually have to manually count the cells in the frame, and then the software will give you a cell count. So it's still doable here in mild to moderate Fuchs, but then when you get to a patient with severe Fuchs, with confluent guttae, for example, getting a cell count here is impossible. So it's difficult to use specular microscopy and endothelial cell counts to assess, or at least have a number in mind that makes our head worry about possible decompensation after cataract surgery. So for me, this isn't a super helpful tool. So what else is out there in the literature? One interesting thing that came out of Rotterdam in the Netherlands is the use of confocal microscopy. And what these authors did was used backscattered light after taking a confocal image. And the implication here is if you have backscattered light, that represents increased corneal hydration status, and this can predict the likelihood of future endothelial keratoplasty. So what these authors are doing is they're looking at various levels in the cornea, and what they found that if they look at the epithelial basal cell layer, you'll see this increased backscatter. And in this image here, you see, this isn't the endothelium, but this is actually the corneal basal epithelium. And you see these darkish, grayish circular areas, and then a lighter, more hyper-reflective linear kind of webbing. And that is that backscatter. And what these authors were able to do in a controlled setting was measure the amount of backscatter that was coming off and quantify this, and then come up with a threshold that if a patient has this amount of backscatter, then they would be better off with the combined procedure addressing both the cataract and the Fuchs dystrophy, which in this case was an endothelial keratoplasty. In this case, it was DSEC, rather than just doing cataract surgery alone. So this was a nice objective measure that could be done. However, the practicality in our typical clinical practices wasn't that great. So for example, not all of us have confocal microscopes. And it is very much operator dependent. So you need to have a microscope, but you also have to have a skilled operator. Then you have to have a way of measuring this backscatter. So for a research study, this was great. It gave a number, an objective number to us, but day-to-day in clinical practice, it may not be ideal. And at Wills Eye Hospital, we don't have a confocal microscope. So even in an academic center, this isn't too practical for us. Now, I mentioned earlier, one thing that I'm looking for is what's the risk of corneal decompensation. The second thing I'm looking for is how much of the limit in vision is being caused by the cornea. So again, we're going to go back to kind of basics here, and probably what we use the most even nowadays is patient history. And the biggest factor that we look for is diurnal variation in vision. So we all know what that is. It's vision that's worst upon wakening first thing in the morning, and patients will, with visually significant Fuchs dystrophy, will tell you that, look, my vision's cloudy for the first maybe hour during the day, and then it gradually clears and gets a little bit better as the day goes on. And this is implying accumulation of corneal edema overnight, and that edema, that subclinical edema, evaporates away as the day goes on. The other thing that Fuchs does is we can get this phenomenon called symptomatic guttae. And this is caused in situations where patients have confluent central guttae, so they may not necessarily have edema that's limiting their vision, but these guttae cause symptoms of blurred vision, glare, decreasing contrast. But if you think about it, that those symptoms are very similar or identical even to the symptoms that are caused by cataracts. So is there a more objective way to determine, how much are these guttae affecting the vision? And the way the vision is affected here is by a phenomena called forward light scatter. So light is coming in, and through a healthy cornea, light goes straight through the cornea, through what's hopefully a clear lens, and gets the retina and reveals a clear image. But when you have these guttae, what can happen is light comes in, it hits these guttae, and then it scatters. And then as it scatters, you get these symptoms of, again, poor vision, decreased contrast, and glare. And what this paper did, we talked about maybe the lack of value of looking at specular microscopy or an endothelial cell count when it comes to assessing Fuchs dystrophy, but the specular microscope can be used for quantifying the guttae, not necessarily quantifying the endothelial cells. So these authors had a novel idea that instead of looking at the cell count, look at the area of the cornea that's covered by guttae. And this was very highly correlated with visual acuity and contrast sensitivity. So in that first image on the left, you've got an area of about 86%. You can see that a lot of guttae there and very little imaging that resembles an endothelial cell. And this correlated very highly with visual acuity that was poor, as well as decreased contrast sensitivity. And then on the right, we see a mild area that's covered with guttae, about 21%, and this patient would have better vision. So this is a quantifiable method that we can use to assess our patients. Now in the real world, these authors, for example, used special software to actually quantify and come up with an actual area number. I do use this in clinical practice. However, it's more of a gestalt analysis. So I'll look at it as either mild, maybe moderate or severe. And if I see nothing that resembles a normal endothelial cell, well, then this makes me worry that the guttae are visually significant and then they do need to be addressed. I don't necessarily have a number that I utilize as a cutoff. So objectively, we are getting there, but practically speaking, I don't think we have, up until this point, what we've talked about is too helpful in our clinics. But what I've been using more and more recently is utilizing the Pentacam that I have in my office, a lot of us have in our offices, and using a piece of diagnostic equipment that I already have and I use for other things, and using it to assess my Fuchs dystrophy patients. So one thing that we're looking at very closely now are the tomographic patterns on the Pentacam map. So this is a map that we should all be familiar with. This is the 4-map refractive map on the Pentacam, where we have an axial curvature, both a front and a back elevation, as well as a corneal thickness map. And when you look at this, and this is a normal patient, just to put things into context, when you look at a normal patient, we see certain things. When we look at the pachymetry map, the corneal thickness map, we see displacement of the thin point of the cornea, and that displacement typically occurs inferotemporally. And on the Pentacam, you can turn on certain toggles where you can turn on what's the center point of the cornea, which is indicated by the top arrow, and then that circle there indicates what the thinnest point is. And here we see that that thin point has been displaced inferotemporally, which is normal. Another thing that we see are regular isopachs. So again, looking at that corneal thickness map, we see that color gradient change. And what we see are very regular concentric circles that emanate out from that thin point on the cornea. And you can see that right here. So you see that circle in the middle, that tiny circle that's already been on the Pentacam map, and that's the thin point. And we see these regular circles of increasing corneal thickness emanating out from that. And that is a normal pattern of corneal thickness progression, what we would call regular isopachs. So again, that is a normal finding. And then the last thing that I'm looking at is I'm looking at posterior elevation. And this is a normal patient, so this patient has a normal posterior elevation. And in just a second here, I'm going to show you what a patient with Fuchs dystrophy would look like. So here's the patient with Fuchs dystrophy. They also happen to have regular with the rule astigmatism. When it comes to analyzing patients with Fuchs dystrophy, I don't look at the axial map a whole lot. I actually honestly don't look at the anterior elevation map a whole lot. The two things that I'm looking for are the corneal thickness map and the posterior elevation map. So in a normal patient, again, we said that that thin point is displaced inferotemporally. Well, here's a patient with Fuchs dystrophy. We can see the thin point is now displaced superiorly. So it deviates from that normal pattern that we see. So this is one characteristic on the pachymetry map that we see in Fuchs dystrophy. The second thing is we lose those regular isopachs that we saw earlier. So if I trace this out, you can see that we don't have those concentric circles anymore. They're no longer uniform, and honestly, they're no longer circular. And this is something that we see a lot in our Fuchs dystrophy patients. And then finally, when looking at the elevation map, what we see is focal posterior depression. Now, admittedly, a lot of us use the Pentacam for following or diagnosing keratoconus, or perhaps in refractive surgery evaluations looking for subclinical keratoconus, poor refractive surgery candidates. And in those situations, what we're looking for is posterior elevation, so posterior protrusion, looking for signs of ectasia. But in Fuchs dystrophy, what we're looking for is actually depression towards the anterior chamber, towards the lens. And that makes sense. If you have subclinical edema, the cornea is actually going to enlarge or thicken And we want to look at that posterior cornea for subtle signs of this. So it may not be readily apparent in this image because the scale of that map is set to what I typically use, and that is what's called the Bellin scale. And what that is meant to do is it's meant to make elevation or anterior protrusion more apparent. But you can change the scales very easily on the Pentacam. And if you change the scale to another preset scale called the OCULUS scale, it essentially inverts it. So going back a slide, in the Bellin scale, as you all know, elevation shows up as a warm color. It shows up as red typically, and depression typically shows up as a cool color. If we switch the scale, what we're now doing is we're making depression show up as a warm color. So this orange area right there are areas of focal depression or posterior depression. Now this is the exact same patient. We just changed the scale, and that area of posterior depression becomes a lot more apparent. And then looking anteriorly, this is kind of the normal central anterior elevation that you'd see in a patient with normal with the rule astigmatism. So the other thing to look for is this difference. Normally the anterior and the posterior cornea behave similarly, but in this patient with Fuchs dystrophy, we have normal anterior elevation centrally and abnormal posterior depression that we see again in subclinical edema in Fuchs dystrophy. So systematically going through a Pentacam like this has been very helpful for me trying to diagnose patients with subclinically significant Fuchs dystrophy. So then the question is, how can we use this information to quantify the risk of progression? And there was a great paper that came out of Mayo Clinic by Sanjay Patel and his co-authors, where they looked at these three parameters. And honestly, these individuals should be credited for looking at these three parameters because they're the ones that really have done a lot of work on this. And what they found is looking at preoperative scans and then following these patients for 4 years after having cataract surgery, if none of these parameters were present, then the 0% of their patients progressed to needing intervention for Fuchs dystrophy. If 1 or 2 of these variables were present, then 50% of these patients progressed to needing intervention. And then if all three of those were present, then 75% of patients had progressed in terms of their Fuchs dystrophy. And what we mean by progression in this study was progression to endothelial keratoplasty or the development of clinically apparent edema or an increase in corneal thickness of at least 5%. So this is a very nice objective way to assess our patients prior to cataract surgery to counsel patients if we're not planning on doing a combined procedure that, look, this is your ballpark chance that this Fuchs dystrophy will get worse after your cataract surgery, or just helping us make the decision that, look, you should probably have a combined procedure here. And we'll talk a little bit about the treatment of both Fuchs and cataract in a little bit. The other neat thing on the Pentacam is using a function called corneal densitometry and using this to assess the cornea for risk factors for progression and look for signs of Fuchs dystrophy. Corneal densitometry, what it is it's a measure of backscattered light that emanates back from the cornea. And on the Pentacam, it's expressed in what are called grayscale units. It's a scale of 0 to 100. And what the implication is if a cornea has opacification, this is going to lead to increased backscatter, and that's what the Pentacam is going to pick up on using this module. And as far as grading, 0 would mean that the cornea is completely transparent, and 100 would mean that the cornea is completely opacified. This is what the corneal densitometry page looks like on the Pentacam. So this may be something that not all of us are familiar with, so I'm just going to take a second to go through the different panes of this. So on the left, what we have are two Scheimpflug images. We have both a horizontal image and a vertical image. And then we have a slider there that says layer 1 and layer 2 right there in the middle underneath layer selection. And what we can do is we can toggle this slider and move anterior to posterior within the cornea and look at the densitometry image in that particular layer. And that's what we see on the left. So in this particular cut, you see a red line on the Scheimpflug images, a red curved line that's all the way anterior, at the level of the epithelium. So that red line is indicating where the image is being taken, and that is what is corresponding on that circular image on the bottom left. So you can toggle through the cornea, look at different layers. You can look at an area of a wider area, so you can turn multiple layers on and look at a zone in the cornea and display that, look at densitometry values. On the right, we have a color map of the maximum densitometry number detected in the cornea throughout the entire cornea, anterior to posterior. And this can be toggled to either look at the maximum number as well as an average number. And then what I find very useful is this table. And this table looks at the average densitometry numbers within certain zones. And you can look at zones in annular rings, so from central to peripheral, and you can also look at specific zones anterior to posterior. So you can look at the anterior 120 microns in the cornea, you can look at the posterior 60 microns in the cornea, or you can look at the area in between that and see what the densitometry is in those zones. And again, you can look within certain annular zones, so you can look at the central 2 millimeters and the anterior 120 microns in the cornea and have an objective number describing corneal opacification. So this, for reference, is a normal cornea. This is a patient with Fuchs dystrophy. So we've toggled that line in the Scheimpflug image to the posterior cornea. So we're basically right at the level of Descemet's membrane. And you can see on the image on the bottom left that we have this white area in the middle, and that white area represents increased densitometry. And we see numbers there that normally were maybe in the 20s, and here we're up to 50. And if you look at the top right, this is again that image that shows maximum densitometry. If you recall on the patient with the normal cornea, it was fairly uniform. The numbers were mostly in the 20s, but here we have this hot spot right in the middle of the cornea where the numbers increased to about 50. We didn't talk about the graphs on the last slide, but in addition to looking at that table and looking at densitometry values within certain zones, this display also graphically represents these numbers as well. So that top of the two graphs, the top graph will map out the densitometry from central to peripheral. And then on the bottom map, it's mapping out the densitometry from anterior to posterior. And one characteristic sign that we see in Fuchs dystrophy is this posterior hump that's indicated by that arrow there. And what that is indicating is this abnormal increase in corneal densitometry that happens in the posterior cornea in patients that have Fuchs dystrophy. As far as numbers, what are considered normal numbers, what are considered abnormal numbers, we're still working as far as large databases, but normal values are typically in the 20s for a normal cornea, and that can go up in patients with Fuchs dystrophy. Now, one thing to keep in mind there are probably certain areas of this chart that are more helpful than others. And what I mean by that is I typically focus on the central 2 millimeters as well as the zone just around that, so the zone of 2 to 6 millimeters, because as you get further out in the periphery, those densitometry values go up, and also it does become affected by certain artifacts that are present in the peripheral cornea. For example, a limbal girdle of Vogt, corneal arcus. Sometimes you can get increased scatter from the limbus and the sclera. So I don't look at for example, outer annulus a whole lot, but when you compare a normal patient on the left to a patient with Fuchs dystrophy on the right, and you look at some of these numbers, you can clearly see that the Fuchs numbers are elevated. And we see that in all of the zones, but most predominantly we see that in the anterior cornea, and we also see that in the posterior cornea, which makes sense. In the posterior cornea, you're going to have corneal guttae, Descemet's haze that will increase densitometry. And in the anterior cornea, you can get subepithelial fibrosis. You can get subepithelial edema that develops at the basal layer of the epithelium, as we talked about earlier. And all these things can increase corneal densitometry values. So again, this potentially is a nice objective way to monitor corneal transparency in a variety of conditions, including Fuchs dystrophy. Here's an example of a patient of mine. So this is a patient on the left, pre-cataract surgery. You can see on the Scheimpflug image the crystal and lenses there. This patient has Fuchs dystrophy. I didn't think it was that bad. And when you look at the densitometry map, it's fairly uniform. The numbers are in their 20s. And when you look on the right, that's the same patient 2 years after cataract surgery. This patient was initially quite happy with her cataract result, but then gradually, little by little, she felt that the vision wasn't as sharp as it was immediately after surgery. So we see that the crystalline lens is gone on the Scheimpflug images, but then if you look at the densitometry map, you can see one on the image on the bottom left, that there are these white specks that are developing, and these numbers are starting to go up. And when you look at the color image, we're seeing higher numbers there, more warm colors there. We're in the 30s and 40s. And taking a closer look at that color map, and then more importantly at the table, you can see preoperatively, let's just look at the total number in the 0 to 2 millimeter zone. Preoperatively, this patient had a densitometry value of 18.5, and postoperatively, in that central zone, it went up to 24.1. So what this data is telling me is that the cornea is becoming more opacified. Now, clinically, it wasn't that apparent on the slit lamp, but we have objective numbers showing increased densitometry. We have a patient complaining of worsening symptoms. So the question is, what do we do here? And the million-dollar question, this patient's already had their cataract surgery. They have a little bit of a PCO. Do I want to YAG that PCO, or does this patient need a corneal intervention? Does this patient need a DMAC? And those of you that do DMAC surgery know that it's certainly a lot easier to do the surgery, more predictable to do the surgery when we have an intact posterior capsule. So you don't want to unnecessarily YAG this patient when the correct answer here is to do a DMAC, because it seems like that the cornea is deteriorating, at least subclinically, and this is the most likely cause for the patient's symptoms. Now the question is, do we have an actual number? In this patient, I looked at a trend, but do we have a number that correlates to one disease or a densitometry level that's visually significant? So, you know, what is that number when patients start to become symptomatic? Is there a correlation there? And right now, to the best of my knowledge, we don't have that. This is a fairly new application that we're learning more and more about. But it would be great that if we had a patient that had a densitometry value of 25 or 30 or 35, that predicts a certain level of visual acuity. I think that is kind of the next step here as far as determining visual significance. But then going back to our earlier conversation, you know, is there a preoperative level prior to cataract surgery that if we got a densitometry value that would predict corneal decompensation after cataract surgery? Just like looking at those tomographic parameters out of that paper from the Mayo Clinic, the same paper also looked at densitometry numbers. And their number that they came up with was 30.5. And if a patient had a densitometry value in the anterior portion of the cornea in that central zone, so that 0 to 2 millimeter zone, if that was above 30.5, that was a prediction of progression of Fuchs dystrophy. Now, this was a weaker predictor than the pachymetry map parameters, but we do have a number there. Having a uniform number, though, is going to be a little bit of a challenge because these numbers can vary depending on the environment that the image is being taken. So for example, my diagnostic room may have different ambient lighting. So my densitometry value compared to Dr. Patel's densitometry value may be different. So having a universal number may be tough to have, but again, this does need to be looked at more and more. So I think we're getting there. There was another paper that was published, again, that looked at preoperative densitometry values and what sort of risk did these patients have going on to need a DMAC in the future. And again, it seems like most of these papers are looking at that anterior corneal zone, that central 0 to 2 millimeters. And this paper did a really nice job of standardizing and really controlling ambient lighting and the process of which these images were taken, but they didn't report the number that the Pentacam reports. So it didn't report in Pentacam grayscale functional units, but instead to a more standardized scatter unit. So they reported a number of 763, but we don't have a way to back correlate that to a Pentacam number. So again, this is an area of diagnostics when it comes to Fuchs dystrophy that's still developing. And as we get more and more experience, we'll be able to utilize this technology, but it is quite exciting. I think we're on the cusp of having some sort of objective measurement that is relevant in the times of DMAC to help guide us as far as how to treat these patients with both Fuchs and cataracts. Now, the final part of this talk is talking a little bit about that surgical treatment and sorting through the different options that we have. So if we've determined that a patient has both significant cataract as well as Fuchs dystrophy, what are the different treatment options that we have available? This patient needs both cataract surgery plus some sort of endothelial procedure. And this has seen an evolution over time. Initially, what a lot of individuals were doing was stage surgery. Cataract surgery first, followed by endothelial keratoplasty. Then it was discovered that combined surgery was both safe and efficient. So surgeons were performing cataract surgery combined with DSEC, which eventually became cataract surgery combined with DMAC. And now, one of the things that I like to do that I'm doing more and more frequently is stage surgery, but doing it the other way around. We'll talk a little bit more about this in just a minute here, but doing stage surgery, doing the DMAC first, and then performing cataract surgery after that. And then lately, the topic of Decimate stripping only, or DSO, has become more and more popular. We won't be touching on that in this talk, but that is also an exciting development in the surgical treatment for Fuchs dystrophy. So let's look at these different options. So the first option, stage procedure, cataract surgery first, followed by endothelial keratoplasty later. The benefits of this, potentially, maybe you can avoid doing a corneal transplant. You know, we've made our determination that both are visually significant, looking at the exam and perhaps the Pentacam at some of these new parameters that we look at. But maybe we do the cataract surgery and the patient's happy with their vision and we spare them a transplant. That would be great. If you do the cataract surgery first, let the eye heal, we could have a more stable IOL configuration, especially when it comes to DMAC. Those of you that do DMAC know that the way we get those grafts unfolded is we shallow the chamber, and we really need that IOL to stay within the capsular bag and not come anteriorly. If you do the cataract surgery first, let the capsule kind of scar around the optic of the IOL, perhaps that IOL will be more stable. You could potentially avoid the use of viscoelastic later on if you're just doing a DMAC by itself. And one thing that maybe isn't talked about that much is if you do stage the procedure, the surgeon reimbursement is higher, whereas if you combine the procedure, the second procedure, the cataract portion of the case, does reimburse half. The cons of doing this, naturally, it's 2 surgeries. The patient has to go to the operating room twice, and there are costs associated with that, both to the patient and to the healthcare system. I think the more popular option is doing combined surgery. So combined cataract surgery plus DMAC. And the pro of this is it's combined, it's one surgery. It's more convenient for the patient, it's more cost effective. And there's a growing body of literature out there by some of the titans in endothelial keratoplasty, Mark Terry, Frank Price, just to name a couple, that there's no evidence of a higher complication rate when combined surgery is performed, and that involves graft attachment, endothelial cell loss, and visual acuity. So it is a safe way to perform surgery. The cons to doing a combined procedure are the refractive outcomes are not as predictable. Typically, what we anticipate with a DMAC is a little bit of a hyperopic shift, not as much as what we get with a DSEC. In DSEC surgery, what we were, predicting for was maybe a 1 diopter hyperopic shift. In DMAC, it's less, but it's not as predictable. Sometimes we see a half a diopter, sometimes we see minimal to no hyperopic shift. Rarely we see a myopic shift, so it can be a little bit all over the place. So the refractive outcomes are a little bit unpredictable still. There is a lower surgeon reimbursement, and you have to be very meticulous during the cataract portion of the case. And if you're going to do combined surgery, certain things that I like to do is when I'm dilating the patient, I don't use cyclopentolate, because you want the pupil dilated during the cataract portion, but you want to bring that pupil down with either Myochol or Myostat, carbachol or acetylcholine when you're performing the DMAC procedure. You want to make sure you get all of the viscoelastic out of the eyes, so we just use cohesive viscoelastic. Those of you that are used to using a dispersive during cataract surgery, it is a little bit of adjustment, and then the feel inside the eye is a little bit different. You want to have a small-ish capsulorhexis, 4.5 to 5 millimeters. And the reason for that is you want that optic to stay within the capsular bag and not prolapse forward during the flattening maneuvers of DMAC surgery. You want to use a hydrophobic IOL. There have been reports of calcification, opacification of hydrophilic IOLs when they're exposed to air or gas, which we do use with DMAC. And as we were talking about targeting the patients, typically what I'll do is I'll aim for a little bit of mild myopia. And this is kind of a go-to, probably the most popular surgical treatment for a patient with both Fuchs and a visually significant cataract surgery. Something a little bit newer is performing a stage procedure, but doing DMAC first. Now, the pros of doing this is you have the best refractive outcome here. You don't have to estimate or guesstimate a hyperopic shift. You essentially do the DMAC, let the cornea stabilize, and then repeat your biometry and get a true keratometry value for that patient's cornea. It opens up the possibility of using different types of lenses. Astigmatism correction is certainly on the table after you perform the DMAC and let the cornea heal. And certain presbyopia correcting IOLs could potentially be an option here as well, that I would shy away from for a combined procedure, again, because you definitely want to hit your refractive target with these premium lens options. And then in a younger patient, perhaps with a little bit of accommodation still, maybe you do the DMAC and the patient sees significantly better. Maybe the Fuchs dystrophy was the main problem. And after taking care of that, we can leave our patients phakic, maybe leave them with a little bit of accommodation, at least for the temporary future. Cons to doing it this way, in addition to having 2 surgeries and the higher costs with that, there's, of course, the concern of damaging the graft, both damaging the endothelium or dislodging the graft during cataract surgery. And the iris does tend to behave a little differently in my experience. Perhaps it's a little bit more flappier. Maybe it was exposure to gas or air at the time of the DMAC. So that can sometimes make things a little bit more challenging. But it's certainly a very doable procedure. There are a few things that take into consideration when it comes to your surgical technique, though, when doing it this way, when doing the DMAC first. I like to make an inferior PI. Because I use SF6 gas, and that gas is going to be in there. 20% SF6 gas, that gas is going to be in there for about 5-6 days. And we want to create an inferior PI that prevents the patients from going into pupillary block. Normally, my standard technique for creating a PI with DMAC is going underneath the iris with an instrument and scratching down on top of that instrument through the iris with the needle. When you have a lens back there, when the patient's phakic, you can't do that. So you have to alter your inferior PI technique using either an anterior vitrector or what's called a Fuchs blade. you want to make sure you size your graft appropriately, and you want to nasally decenter it just a little bit so you give yourself a little bit more room temporally, so that when you go back in with your cataract surgery, you of course want to be careful with your instruments coming in and out of the eye, but you have a little bit more room to work with, so you don't accidentally knock the edge of that DMAC graft off. You want to take care of that endothelium when you're doing the cataract surgery, so use a dispersive viscoelastic or use a soft shell technique, and then use some sort of intracameral mydriatic. I like to use either epi-sugarcane or a Midria to keep that pupil nice and dilated, especially if it's looking a little floppy. I would avoid this sort of staged approach in a patient with a very dense lens or a very small anterior chamber depth, just because that is added risk to that DMAC graft. So this is a surgical video of me performing a phakic DMAC. It's very similar to a pseudophakic DMAC, except again, the PI creation is a little bit different. This is what's called a Fugo blade. It's a plasma blade that creates a very precise hole in the peripheral cornea without bleeding or much inflammation. So this is a great option. Unfortunately, it's not readily available. It's actually an old device and it's hard to get the parts for it, but if you have one, it's great. The next step, just like any DMAC, is to strip, score, and remove Descemet's membrane in its entirety. I like to overstrip, so I use a 7.75 millimeter graft, so I'll strip a diameter that's greater than 8 millimeters. We'll go ahead and insert our graft. We're using preloaded tissue right now, and this is loaded onto a Guder cannula, so it goes through a 2.4 millimeter corneal incision. So we'll go ahead and insert it into the eye, and then shallow the chamber, and then through some fluid modulation that's in our cannula, we'll go ahead and spin the graft, shallow the chamber, and then remove that cannula. And by using that technique, the graft actually opens up a little bit. Now, the graft in a phakic patient actually opens up fairly easily because the key is to shallow the chamber. And by having a phakic lens behind the iris, we're actually able to shallow the chamber a little bit easier. Sometimes what can happen though is that graft can get caught up in the angle because it's especially shallow there. So sometimes we have to actually deepen the chamber with a little bit of balanced salt solution. But this is standard DMAC technique with taps and fluid modulation, getting that graft centered, putting in our bubble of SF6 gas, and we're essentially done. We have the patient stay supine for an hour in the recovery room, set them upright, and make sure that we have the right amount of gas in the eye. So in this situation, then what we would do is we would follow the patient, wait 3 months, let that DMAC heal, repeat our biometry measurements, and then come back and do cataract surgery. When it comes to the cataract operation, again, really it's your standard phaco, but you just have to be careful making your incisions and coming in and out of the eye. The most likely point where you would dislodge your graft is either by making an incision or hitting the edge of the graft coming in and out of the eye with one of your instruments. So the key is to make note of exactly where that DMAC graft is sitting and then just pay very close attention to that when you're making your incisions. So when you're making your paracentesis, again, stay posterior to the edge of the DMAC. We'll go ahead and use a generous amount of a dispersive viscoelastic. As far as the main incision, we'll just go ahead and open up our prior DMAC incision. So I'll go ahead and use the same incision I used. Perform, a capsulorhexis, hydrodissection like we normally would. We'll do a little hydrodelineation. Go ahead and be careful inserting that phaco handpiece. I like to lift the lip of the incision with the second instrument. We'll go ahead and remove the cataract with your preferred method of nuclear disassembly, remove the cortex, and then insert the lens. One thing that I wouldn't recommend is using wound-assisted lens insertion if you're doing it underneath the DMAC. So I'll go in all the way through the incision, go ahead and insert the lens, and then hydrate the wound. The other kind of small modification is when hydrating the wounds, typically what I like to do is hydrate the roof of the incision. But when there's a DMAC graft there, I avoid that and I'll just hydrate the walls of the incision. So with a few minor tweaks, we can perform this surgery staged, but kind of reverse of what we would classically think of as staged approach. And this is a nice option for that patient that really wants a specific refractive outcome, or really wants their astigmatism corrected, or is really motivated to have some sort of presbyopia correction at the time of cataract surgery. It really has opened up new opportunities, and we can almost do refractive cataract surgery in the setting of prior corneal transplantation. And you know, just a few years ago, we would have thought that's not even possible. So to summarize, as we wind up this talk, you know, I've got three main points that I'd like you all to take away from this. First and foremost, clinical history and exam is paramount to assessing the visual significance of Fuchs dystrophy, but that's really most helpful in clinically apparent edema. Now, when we have subclinical disease, we're looking for some sort of metric or some sort of objective parameter that helps us guide treatment. And in my opinion, there is good value in using the Pentacam for both tomographic patterns as well as corneal densitometry in trying to evaluate these patients prior to cataract surgery. And then finally, it's a nice time to look at a combined versus a staged treatment of cataracts and Fuchs dystrophy, and consider treating the DMAC first, letting the eye heal, and then performing cataract surgery after that. That wraps up my talk. I would just like to thank everyone for joining. And at this point, I would like to open up the floor to any questions. So Carver, if anything's come in, please feel free to ask.
Yeah, Dr. Meghpara, great job. Very fascinating presentation. We did get a bunch of questions, a couple of which you actually answered along the way,
Okay.
but I'm going to keep them anyway because I think they're good questions. The first one, how long do you wait between the cataract and the DMAC if you're doing that stage procedure? And I think you did talk about that at one point, but I think it's worth repeating.
Yeah, so it depends. So if we're going to do the cataract surgery first and then the DMAC surgery second, usually I just wait about a month and a half, because the cornea isn't clearing, the patient's not happy with their vision, we want to get on to the DMAC, so maybe a month. But if we're doing it the other way, the DMAC first and then the cataract surgery, we have to wait longer. So there I wait 3 months. I let the DMAC completely heal, I let the cornea normalize, I let the IOL calc stabilize, get a new set of IOL measurements, and then do the cataract surgery.
Excellent. A question about the Pentacam scale and switching that Pentacam scale. Does changing the scale simply switch the color scheme, or does it actually somehow highlight the subtle changes in some other way?
It just switches the color scheme. Now you can also change the numerical values of the scale, so the interval, but all I do is I just change the color scheme. And this might just be me, but my eyes pick up that red spot, that warm spot, a lot easier than picking up a subtle change from, you know, green to blue. Yeah, my eyes see that change from green to orange a lot better. So it's just changing the colors.
A related question, but slightly different. As a corneal specialist, do you leave your Pentacam defaulted on the Beeran color scheme, or do you leave it on the Oculus color scheme? And for what reason do you choose to leave it one way or the other?
That's a great question. I right now leave it on the Beeran color scheme, because again, predominantly, even as a corneal specialist, what we're using our Pentacam for is keratoconus screening, keratoconus progression, and refractive surgery screening. So in that, I do think the Beeran scale is more useful. So for me, I'm still leaving it on that. And the other thing is, you know, if you have multiple doctors in your practice, my two partners like the Beeran scale. So if I switch it to the Oculus scale, I got to make sure I switch it back to the Beeran scale, otherwise they're going to be unhappy.
So, and another related question to the color scale, when you switch it to the Oculus color scale, is there a certain cutoff number that you find useful when looking at that posterior elevation with the Oculus color scheme?
Yeah, as far as an actual number, I would say -10 or -15. But really for me, it's pattern recognition. When looking at the Pentacam as far as these parameters, there really isn't a number. So there isn't a number of how deviated these isobars have to be or how far the thin point has to be. It's more of a binary thing, yes or no. At least that's how the analysis in Dr. Patel's paper was done. And that's the same approach that I use. So it's more recognition. There is an area of depression there, not so much how much is that depression occurring.
Gotcha. On a somewhat related topic, does the size of the opaque area correlate with the light scattering? So when you see that opacity on the densitometry, does that correlate with the light scattering?
We think so, and clinically that makes sense. So the size of that opacified matter, yeah, I think the bigger it is, the more encompasses the visual axis, the more light scattering and the more symptoms that we're going to get. So I do look at the size and kind of use that as, I don't have a number, but just kind of a gestalt. This looks more severe than something that's very, very focal.
And do you ever use corneal densitometry to screen premium IOL patients on healthy corneas, since multifocal and EDOF IOLs are going to, again, be sensitive to light scatter? So is that something you look at all in the non-Fuchs patient, just as a useful measure of scatter?
That is a great question, and I'm honestly not doing that. The other thing, what I am doing is looking at on the Pentacam higher order aberrations, spherical aberrations, but I have not looked closely at densitometry when it comes to screening for premium lens patients. But that's a great question. And I think it highlights kind of all the data that's available on the Pentacam. We've had it for a while, and I'm, as a cornea specialist, still learning more and more and newer uses for it. So I think that's a great idea, whoever asked that question.
Yeah, and I guess retrospective looking at data will be very helpful in trying to figure out the answer to questions just like that.
Exactly. You have an unhappy premium IOL patient, everything else looks okay, but maybe we should have looked at that densitometry value.
So I have a question myself I wanted to ask you. You mentioned a lot of the different variables that go into deciding whether you do a stage procedure or even if you do any corneal procedure when you have Fuchs and a cataract combined. How does age play into that? So if let's say you have a 58-year-old patient with a cataract, a young patient, versus a 75-year-old with the same cataract, does age come into that factor at all, knowing the lifespan of that cornea? And how do you look at age?
It does. It does. And actually, I get more aggressive. Let's say we have equal cataract densities, equal Fuchs dystrophy severity. In that younger patient, I tell them, now I don't necessarily push them into surgery, but I tell them, I don't think this cornea is going to last for the rest of your time on this planet. Whereas if I had, an 85-year-old patient with the exact same numbers, maybe we can get them 15, 20 years out of that cornea. So definitely when it comes to counseling, it's really important. As far as surgical decision-making, I think we all also intervening a little bit sooner in those younger patients. I think in general, we're intervening sooner just because of the success of DMAC surgery.
Excellent. Let me just see. I think something else may have just come in. Can the Pentacam be used to get an objective measure of the visual significance of central confluent guttae in the absence of corneal edema or cataract?
Yeah, so that's something that we don't have a number yet, and I was briefly mentioning that. I mean, you can take that densitometry image, bring it all the way down to the posterior cornea, and actually see a map of that backscatter of that increased densitometry. But do we have a number that if it's 40, it's not going to affect the vision that much, but if it's 55, it will. We just don't have that data yet. So right now, there is no specific number that we're looking for, but certainly if we see a big patch there, that's definitely a red flag.
That sounds like an exciting project to look into.
Exactly.
Well, what a lot of fun tonight was, and this was really a very fascinating presentation. I really appreciate you tonight. This was really interesting, and I want to thank everyone for coming tonight and all the great questions that we got. On behalf of Oculus, again, thank you so much, and have a great evening.
Yeah, thank you. Thank you for joining, everybody.